Thank you for giving me the opportunity to talk in this session. Today I'd like to talk about this theme. We previously identified the locations of focal hypo-fluorescent areas, FHFA, on late phase ICGA in patients with CSC using ANFAS OCT. Volume data of the posterior pole were acquired. The data were automatically segmented and flattened using prototype software with Brooks membrane serving as a reference plane. This ANFAS OCT image was taken at a depth of 15.6 micrometer. This ANFAS OCT images were obtained at a depth of 130 micrometer. This image was obtained at a depth of 260 micrometer. As you can see, FHFA on late phase ICGA corresponded to abnormal hyperrefractive areas around the level of the reference plane on the ANFAS OCT. These FHFA on ICGA were detected in all CSC eyes and even in 52% fellow eyes without SRD. However, little is known about their etiology or clinical course. Therefore, we aimed to demonstrate the prevalence of FHFA on ICGA in fellow eyes of CSC and evaluate their possible associations with the development of SRD. Unilateral CSC patients who were followed up for more than 3 months were retrospectively reviewed. We included the images of late phase ICGA at baseline. Now, let me show you our results. This is a 44-year-old man. FHFA was observed above the arcade vessel. 1 year later, SRD was confirmed at the site where FHFA had been detected the previous year. This is a 41-year-old man. FHFA was observed near the arcade vessel. 1 year later, small SLD was confirmed at that portion, small. In total, 32 CSC fellow eyes were followed up. Mean follow-up duration was 16.7 months. FHFA in the fellow eye at the baseline were detected in 68 to 8%. There was no statistically significant difference in the follow-up duration between eyes with and without FHFA. During follow-up, 9 out of 22 patients with FHFA developed an SRD. In contrast, none of the 10 eyes without FHFA, that is, with normal ICGA, developed SRD. The statistical significance of differences in SRD development between the groups with and without FHFA was confirmed. We considered 3 possible explanations for the hypo-fluorescence on late phase ICGA. First, let me discuss the possibility of choriocapillaris atrophy at the site of FHFA. This is a 34-year-old man. SLD was observed in the right eye, but not in the left eye on OCT. Hyperfluorescence was observed in both eyes at 5 minutes on ICGA, and also present in both eyes at 10 minutes. However, FHFA was observed in both eyes in the late phase of ICGA. From these findings, we consider choriocapillaris atrophy to not be the main reason for FHFA, because Hyperfluorescence was detectable until the middle phase of ICGA. Second, let me explain the possible roles of sodium, potassium, and ATP as pump disorder in the RPE. Chang and colleagues showed that when RP cells are severely damaged, the ICG may then enter via the damaged cell membrane. However, they also noted the possibility that if RP cell damage is still mild, RP cells may not take up ICG. This hypothesis is possible. Third, let me discuss the theoretical substances between the RP and the Brooks membrane at FHFA. Usually, ICG extravasates from the fenestrated choriocapillaris. If deposits such as lipids accumulate beneath the RPE, ICG may not be delivered towards the RPE. Chang and colleagues reported that the RP overlying drusen deposits showed reduced fluorescence. ICG has the characteristic of binding to phospholipids, but other compounds such as esterified cholesterol, unesterified cholesterol, triacylglycerol are not readily bound. These pathological images show changes with aging at the Brooks membrane level. This patient is over 60 years old. Esterified cholesterol and unesterified cholesterol are deposited at the Brooks membrane. In this case, we knew that there was something beneath the RPE in OCT. In other words, between the RPE and the Brooks membrane. Substances which don't combine with ICG may show hypo-fluorescence. This hypothesis is also possible. In conclusion, FHFA are present in 2/3 of fellow eyes of CLC on late phase ICGA, and their presence may constitute an indicator of subsequent SRD risk. Thank you for your attention.